But this is an important subject and ties into a lot of our neuroanatomy that we covered in the first year. So the pathways, three in particular that we talked about in the first year neuroscience course, will allow you to figure out so much in terms of localizing lesions in the spinal cord. So first of all, of course, we have the posterior columns, the fasciculus grossalis and cuneatus. Remember, this conveys vibration and proprioception, which gets there from the large myelinated fibers that enter the cord and ascend without synapsing. Out laterally, we have the lateral cortical spinal tract. So this is our classic upper motor neuron pathway, and the spinothalamic tract conveying pain and temperature. So let's follow that. Okay, so pain and temperature fibers come in through small, relatively unmyelinated fibers, synapse in the substantia gelatinosa, and then cross over here in the ventral white commissure and ascent. All right, so this is crossed, which is very important. Also, the columnar arrangement here is important. Notice that with the posterior columns, the sacral fibers are medial, then lumbar, thoracic, and then cervical are lateral, and we have exactly the opposite relationship here with the lateral cortical spinal tract and the spinothalamic tract. All right, and here we have the anterior horn cells and the ventral horn. These are the lower motor neurons that will supply muscles in the arms and legs. And at this level, at C5, this would supply muscles like deltoids, biceps, supra and infraspinatus, brachioradialis, and so on. Okay, and then we have the dorsal and ventral spinocerebellar tracts out very laterally in the spinal cord. I would really suggest, if you haven't started on the board review handout, that you do that. Pictures like this are labeled. Not everything that's labeled, so this is a condensed handout, so I try to pick the high yield information, but I'll just remind you that we can tell this is thoracic cord because of the small ventral horn, the distinctive intramediolateral cell column here, which are the preganglionic sympathetic fibers, and then we've got Clark's nucleus right here. Remember, that is the relay nucleus for the dorsal spinocerebellar tract, which travels out here. Also, we can see the substantia gelatinosa here, pain and temperature, pain especially will synapse here, and then here we have Lissauer's tract. Recall that pain and temperature, as it enters in, ascends for a segment or two before synapsing in substantia gelatinosa, and then crossing over in the ventral white commissure and out here into the spinothalamic tract. So remember the cortical spinal tract, which I won't review in detail here because we have gone over this so many times, but we're in the spinal cord right now. So just remember that if we have a hemisection of one half of the spinal cord, the weakness will be on the same side. The upper motor neuron findings will be on the same side as the lesion. Okay, but it would be worthwhile to maybe just pause the talk right now and just remind yourself of the posterior limb of the internal capsule and the important location of the cortical spinal tract all the way down. All right, the spinothalamic tract, of course, I just said that ascends in Lissauer's tract, crosses over in the ventral white commissure, and ascends. So we will see that if we have a hemisection of the spinal cord, the pain and temperature deficits will be on the opposite side. And then, of course, we have the posterior columns. This information for vibration and proprioception does not cross in the spinal cord. Therefore, if we have a lesion here on the left side, the vibration and proprioception deficits will be on the same side. So we're going to divide our clinical aspects of the spinal cord into 5 major categories. Spinal cord diseases with prominent upper motor neuron findings, or prominent lower motor neuron findings, or a mixture. And then we'll see there are a few conditions where we get mainly sensory findings. And then we'll just talk about one condition, Friedreich's ataxia, which is a hereditary myelopathy. The term myelopathy you should associate with spinal cord diseases. It really indicates the upper motor neuron manifestation of spinal cord diseases. All right, so probably the most common condition of all that we'll talk about in this lecture is a compressive myelopathy. Something is pushing on the spinal cord. Two most common causes would be spondylosis, mainly something in older individuals where over time with degeneration and little osteophyte spurs that form, we get a narrowing or an encroachment around the spinal cord. Younger individuals would be more likely to have a disc herniation, where we have an abrupt herniation, maybe related to playing a sport or a fall or lifting something, and then that compresses the spinal cord. So we will see both of these are most likely to affect the cervical cord. Then we have a number of cancers which can travel to the spinal cord. So these are metastatic, and these tend to affect more likely the lower portion of the spinal cord. And a way to remember the different cancers that can do this is the mnemonic lead kettle. So prostate, breast, kidney, thyroid, and lung. So the three most common here would be prostate, breast, and lung cancer that go to the spinal cord. So this is a neurologic emergency because there are things we can do for these patients and it needs to be done quickly. Then we have tumors that can grow in and around the spinal cord, and these can either be, if they're growing outside the cord and pushing in, we call them extramedullary. So neurofibromas, schwannomas, and meningiomas would all be examples of that. We will later talk about neurofibromatosis, and we'll remind you that that's a condition where these tumors can grow and push the spinal cord. Intramedullary tumors grow within the spinal cord. And the two most common here are ependymomas and astrocytomas. Dr. Deich in his 2 lectures on nervous system tumors will go over these. And we can have different vascular things that can compress the spinal cord. Vascular malformations are like an arteriovenous malformation, is a tangle of blood vessels that are leaky, and they tend to, over time, compress the spinal cord if they're in that area. And just like we discussed trauma producing epidural and subdural hematomas that involve the brain, trauma can also cause blood to either occur inside or outside of the dura, compressing the spinal cord. And then finally we can have an abscess that can compress on the spinal cord. This can be associated with IV drug use and a number of other things. All right, so let's spend a little more time about spondylosis and disc herniation. Again, it is more likely cervical, and so when something compresses the cervical spinal cord, usually, the spinal cord is not very big, so if you push on the spinal cord, there tends to be swelling throughout the spinal cord, and so patients usually have bilateral upper motor neuron weakness, and remember that's spastic, kind of a stiff weakness with hyperreflexia, clonus, and upper motor neuron findings, but they'll have all of that below the level of the lesion. Now, one thing that's a important clue about specifically what level you're dealing with is to consider the nerve roots that are involved. Because if we're pushing on the spinal cord, the nerve roots are right there, right? So let's say we have a disc pushing at C6. Well, that patient will have upper motor neuron findings below C6, but at the level of C6, that patient will probably have shooting pain down the arm, and if you remember that the C6 dermatome goes down to the thumb, and the patient says, yeah, my thumb is numb, then you could be pretty confident not just that it's cervical cord, but that it's C6 cervical cord. Frequently, the posterior columns will be involved as well, and if you remember that conveys vibration proprioception, then you'll understand that these patients have a second reason for having gait instability. Not only do they have spasticity in the legs, but they also don't have good proprioception. So you'll look for vibration and proprioception deficits on exam. Lhermitte's sign is a helpful clinical indicator of a spinal cord disease, more specifically of something going on in the posterior columns. And this describes the feeling of an electrical sensation that travels through the body. It's usually triggered, if it's in the cervical spinal cord, by neck flexure neck flexion, and patients say that something just shoots like a jolt of electricity down their spine. So when you hear that historically, you want to think about spinal cord. Something's going on with the spinal cord, posterior columns. Okay, at the end of this lecture, we will talk about innervation of the bladder. Now, the anatomy of the bowel and bladder through the spinal cord is very complex, but if you have a lesion of the spinal cord, it usually ends up disrupting these pathways, and patients have bowel and bladder dysfunction. So as a rule, if you've got a spinal cord lesion, there will very likely be some problems there that your patients will have. All right, so again, if we've got a lesion, disc, whatever it is, pushing at C5, there tends to be some swelling throughout the cord, and so we're going to have lots of motor and sensory symptoms below the level of the lesion. And here is just showing the sensory root coming in here. So if our disc is here at C5, then we're going to have pain going into the shoulder. If we involve the motor roots at C5, we'll have some weakness of those C5 muscles. So Brown-Séquard syndrome, super high yield as we discussed last year. And so just recall that the three pathways that are most important in involvement of Brown-Séquard is the corticospinal tract, producing ipsilateral spastic weakness below the level of the lesion, ipsilateral loss of vibration and proprioception below the level of the lesion, and contralateral loss of pain and temperature below the level of the lesion. So sometimes something pushing on the cord will preferentially involve one half of the cord more than the other. And so that's when we'll see our Brown-Séquard syndrome. There's nothing else that does that. So if you've got that crossed finding with loss of pain and temperature on the opposite side, the lesion has to be spinal cord. Now, I didn't used to talk about this, but then a couple of years ago, a student emailed me and said this was on a board exam, so we're covering it now. Something we don't do very often in clinical neurology, and that is checking for superficial abdominal reflexes. You do this by taking something sharp, you strike it across the abdomen, and you look for contraction of the muscle in that area. And this reflex is unlike the deep tendon or muscle stretch reflexes that we've talked about earlier, like the patella or the biceps reflex. Those reflexes just go to the spinal cord and right back out to the muscle that was stretched. Superficial abdominal reflexes actually loop all the way up to the brain. And so if you disrupt that connection between the abdomen and the brain, like a spinal cord lesion, then these reflexes disappear. Okay, so the absence of superficial abdominal reflexes are seen with lesions above T8-12. Okay, and so the reason I said we don't check these very often is it's very difficult to elicit that in normal individuals, especially if they're just a little bit overweight. So if we have a thin individual, then we can often detect this reflex, but it's absent in just a lot of normal individuals. So that's why it's practically not very helpful, but I guess for a board exam you should know about it. So here's a patient with disc herniation here at C5-6. Notice that above that, this white here is normal. This is a CSF cushion around the cervical cord. So this part all looks normal. Here we can see a disc herniation here because it gets really small. And then here we not only have a disc herniation, but we can see swelling within the spinal cord. And then looking pretty normal below that. All right, so we've got a significant cervical spinal stenosis here with swelling in the cord. Now a lesion like that, if it's above T6, will commonly produce what's known as autonomic dysreflexia. I think we most often see this in a real bad spinal cord trauma where the lesion is above T6. And this often takes a little time to develop, but after a month or so or within the first year, patients have these very dramatic episodes which essentially are due to unregulated overactivation of the sympathetic nervous system. All right, and so this is usually triggered by something, pain, sometimes sexual activity. I think what I've seen most often are one of two circumstances. The patient has a full bladder, or because of their inability to empty their bladder, maybe they have a catheter in, and changing the catheter, which can be quite uncomfortable. This will often trigger this very dramatic response. And so just think about the sympathetic system going wild. Your blood pressure is going to go up, usually the pulse will go up, patients are complaining of a headache, they're feeling anxious, they're sweating or diaphoretic. And so patients will describe these very uncomfortable episodes. And this is important to recognize because blood pressure can go alarmingly high and can be quite serious. So we try to do things to reduce triggers that will cause that. And there's some other treatment options, but the main concerning issue is extremely high blood pressure during the episodes. Now, so here we have a disc right here, and it's pushing on the spinal cord. You can see it's also pushing on nerve roots, right? So at the level of the lesion, we'll have focal, motor, and sensory symptoms, and we'll get frequently swelling throughout the spinal cord. So the drawing here is not meant to be anatomically accurate, because if our lesion was right here, well, this is about T4. The arms don't have any T4 in them, so it would really just be from the chest down. But the point here that the student who drew this was trying to make is below the level of the lesion, look for one of these three things going on. Here in purple, corticospinal tract. So we'll get spastic weakness below the level of the lesion. Here in green, we have the spinothalamic tract. So we'll have loss of pain and temperature below the level of the lesion. And here are the posterior columns. So we'll get loss of vibration and proprioception below the level of the lesion. Now, acute spinal cord trauma can cause kind of a shearing effect in the cord and can just acutely disrupt these motor and sensory pathways. So this often relates to motor vehicle, motorcycle accidents, or some sort of a sports injury, football, diving, or other trauma like a stab wound, gunshot wound that affects the spinal cord. If it's related to a car accident or a football injury or something like that, it's most likely to occur around areas of the spinal cord that are mobile around areas that are stable. And those areas are the atlantoaxial joint, the low cervical spinal cord, and then thoracolumbar junction and lumbosacral regions. So depending on the extent of the injury, if only part of it is involved, you may get a Brown-Séquard syndrome. If it's complete, then the patient will be paralyzed below the level of the lesion and have complete loss of sensation below the level of the lesion. Okay, so when this is due to acute trauma, we give high-dose steroids, which can help, and then frequently we need to get a neurosurgeon involved if there's something compressing the spinal cord. So here's a case of significant, we have a hematoma here behind the cervical cord, and then we've got an obviously abnormal kinking here of the spinal cord, cervical spinal cord. Now, transverse myelitis, you want to pretty much associate that with multiple sclerosis. Okay? Not always, but that's by far the most common cause. So this is a non-traumatic inflammation of the spinal cord. MS, as we'll discuss next time, is a condition that affects younger individuals. So if this is the first episode of MS that they've had, these are young, healthy people that come down with a rapidly progressive weakness and sensory loss, usually in their legs. So most commonly, the swelling is in the thoracic cord, so the arms are not involved, usually. And so they come to an emergency room. They were normal when they went to bed, and they woke up with a lot of leg weakness and numbness. So from the disruption of upper motor neuron pathways, they're going to have upper motor neuron findings. However, it's important you've at least heard about this condition called spinal cord shock. This can happen with any acute lesion of the spinal cord, and it's quite common with transverse myelitis. And basically what this describes is that the upper motor neuron manifestations that you expect to see in spinal cord lesions may take a little time to develop. All right, so someone coming into the emergency room with transverse myelitis, and you've done your exam, maybe they're weak and they're numb, like below the nipple level. And so you say, yeah, this has to be thoracic cord. You confidently get your reflex hammer out, expecting to find hyperreflexia in the legs, and the reflexes are absent. And so this is spinal cord shock. Now, if you come back and check that patient a few hours later or the next day, then the hyperreflexia and the clonus and all of that will come out. All right, so that can be a little bit confusing if you've not heard of that. One other thing that is common with transverse myelitis is that patients will frequently, at the level of the lesion, have a sensation of a tight band being pulled. So if their inflammation is at T10, then they've got something tight, like around the umbilicus. And so I'll explain why that is in just a minute. Okay, and with anything that affects a large portion of the spinal cord, they're going to have bowel and bladder dysfunction. So let's imagine we've got a lot of inflammation here affecting the here at T1 of the spinal cord. Well, here are the pain and temperature fibers, right? And of course, the same thing is happening over here. It's not drawn. And so the tight band is created from a disruption of the pain and temperature fibers where they cross over right here. It just creates that kind of an uncomfortable sensation. Now, at the end of this course, we'll have a lecture on neurologic complications of HIV, and at that time I'll tell you that 20% of patients who have AIDS will develop this AIDS myelopathy. It's usually in the cervical cord, and it's kind of just a degeneration that occurs of the cervical cord. The most common stroke of the spinal cord involves the anterior spinal artery, and so the two most common stroke risk factors are diabetes and hypertension. So these are risk factors we'll see with strokes in the brain and the spinal cord. This is also something that will often occur after or during thoracic artery surgery. So the blood vessel to remember here is the artery of Adam Kavitz, which I will show on the next slide. So the anterior spinal artery supplies this whole portion of the spinal cord. Notice not the posterior columns. So these patients have paralysis below the level of the lesion. They have loss of pain and temperature below the level of the lesion, but vibration and proprioception is normal. All right, so what is it with the artery of Adam Kavitz? Well, remember that blood vessels here, radicular arteries, travel right along with the nerve roots. And along the course of the spinal cord, there are only about 7 or 8 of these that meaningfully boost supply to the spinal cord. Most of them just supply the nerve roots. But the largest radicular artery right here is the artery of Adam Kavitz. So you can see this is majorly boosting the anterior spinal artery here. So since the artery of Adam Kavitz supplies the lower up to the mid-thoracic cord, there's a watershed area just above that. And so if someone's having surgery on the aorta, then they can have some diminished blood flow here to the artery of Adam Kavitz, and they may have a stroke just above this distribution. Okay, so that blood vessel is important. Here are a couple of drawings showing you the anterior spinal artery. So the stroke is here, but not involving the posterior columns. All right, so if we have a patient with a spinal cord injury, the spasticity can really limit their ability to walk. It can be uncomfortable. Clonus, remember that finding on exam, can sometimes just happen spontaneously in these patients, and the whole leg will shake. So there are a variety of things that can be done for patients that are having spasticity. Baclofen is probably the medication that is used first. It's a medication that stimulates GABA A receptors in the spinal cord. Remember that GABA is an inhibitory neurotransmitter, and so having that additional inhibition in the spinal cord tends to quiet down neurons that are overactive, causing the spasticity. So this can be given orally, and in severe cases we can put in what's called an intrathecal pump, where the baclofen is delivered right into the cerebral spinal fluid. Right? Benzodiazepines are another class of medications that can help with spasticity. Diazepam or Valium is the one probably used most often for spasticity. And we'll get into the mechanism of this in the seizure lecture because benzodiazepines are frequently used to abort seizures when they're ongoing. But here is the GABA receptor. So our baclofen is going to act here. And notice on the GABA receptor, there's also a site for benzodiazepines. The reason we don't like to start with benzodiazepines is they're quite sedating and much less so in the case of baclofen. Another thing we can do for spasticity is to inject botulinum toxin into the muscles that are very spastic. So remember, this is going to disrupt the snare proteins, decreased release of acetylcholine, and so the muscles that are supplied by those nerves will actually be a little bit weaker, but that's a good thing if they're always overactive from the upper motor neuron lesion. So that lasts about 3 months, and then patients just need to keep coming in and getting their injections. All right, next we have two conditions that just affect lower motor neurons in the spinal cord. The first is polio, which was very common, more than 50, 60 years ago. We occasionally see polio in patients who don't receive immunizations, but not very often. And polio, you want to associate with a degeneration of the anterior horn cells. So prior to Guillain-Barré, this was the most common cause, or prior to the treatment for polio, this was the most common cause of an acute flaccid paralysis. So it tends to affect more the legs than the arms for most patients. It's usually asymmetrical, so one leg's going to be affected more than the other. And of course, anterior horn cells are the lower motor neurons in the spinal cord. So we're going to have lower motor neuron findings like atrophy, fasciculations, loss of reflexes. Usually with anterior horn cell diseases, there are quite a lot of cramps, so that's common. But of course, anterior horn cells have nothing to do with sensation, right? So that patient with atrophy and weakness of one leg will have normal pain, temperature, vibration, and proprioception sensation. So a lot to admire here about Dr. Salk not wanting to patent or become rich here from his invention. So you'll learn more about this in microbiology, but most individuals that get polio or are exposed to this virus are not symptomatic. So less than 10% have usually what are minor symptoms, and it's very small, 0.1%, that will develop a meningitis or an encephalitis and affect the anterior horn cells. So the mechanism here is that the poliovirus travels via retrograde axonal transport up to the spinal cord and to the brain. Okay, and so for this lecture, we're concerned about those anterior horn cells. And so patients in this setting of a meningitis, encephalitis, that then develop lower motor neuron weakness, that is a good description of polio. Sometimes the lower motor neurons in the medulla that are important for talking and swallowing can be affected, and so occasionally that can be part of the syndrome. So we can do PCR analysis for the poliovirus in the spinal fluid, and treatment is supportive in recognizing that respiratory muscles are affected, or the anterior horn cells that supply respiratory muscles are affected in some patients, so we do need to monitor for respiratory failure. Right, so here's a nice drawing showing you the lesion here of the anterior horn cells, and then we're going to get Wallerian degeneration here of the motor route through the plexus and peripheral nerves. So if this is mainly lumbosacral anterior horn cells, then the weakness will be mainly in the lower extremities. So it can affect the cervical cord, and we can have some arm weakness, but the legs are much more common. All right, West Nile virus is the sort of the modern day equivalent of the poliovirus. So this is transmitted by mosquito bites, and this is the time of year when we begin to see these cases, late summer, early fall. So you can see that really prior to 2000, I think 1999 is when things kind of began to pick up. This was very uncommon, and I think we've been hovering around 2,000 or so cases per year that are neuroinvasive, the really severe cases. So you can see that when we look at counties across the United States where this is most common, well, this is where mosquitoes are. And I can testify that on our camping trip up to North Dakota a few years ago and going through Nebraska and Colorado, lots and lots of mosquitoes. So it's a little more common in those areas. So there's an incubation period after the mosquito bite that can be for up to 2 weeks. And again, most people have no symptoms. About a quarter will have what is called a West Nile fever, and many of these individuals don't seek medical treatment. They have a fever, a headache, a rash. They may see their doctor later and say they had the flu or something like that. All right, but the severe involvement involving the brain and the spinal cord is less than 1%. So most often this is a meningitis and an encephalitis. Remember the difference there. Encephalitis implies we have actual swelling in the brain itself. If we just use the term meningitis, it's a swelling around the coverings of the brain. And so you'd much rather, not have an encephalitis because that can cause seizures and all kinds of other complications. So you can see that the least common complication, but I have seen a number of individuals with this, is where the anterior horn cells are knocked out. So it's like polio. The story is headache, meningitis, maybe an encephalitis, and then lower motor neuron weakness. In that context, if you see a patient like that today, it's West Nile virus. So we can diagnose this by a IgM serum test. This can also be done on the spinal fluid. Anytime someone has a meningitis, encephalitis, they're going to have elevated white cells in the spinal fluid, mainly lymphocytes, and because it's viral, the glucose will be normal. Okay, remember, protein goes up when almost anything is wrong, involving something infectious, meningitis, encephalitis. But the glucose is so helpful. If the glucose is low, then you're thinking fungal infection or bacterial infection. But this is a virus, so your glucose is normal. Okay, if our patient had encephalitis and we do an MRI scan, we may actually see that swelling on the MRI scan. And you don't need to worry about what that appears like, but we can see some abnormal signal intensities. All right, ALS is our condition that involves both upper and lower motor neurons, amyotrophic lateral sclerosis. Patients, of course, will know this as Lou Gehrig's disease. And really, if you want to use a descriptive term, motor neuron disease is really a great term for this because it really describes what is going on. So recall that ALS is a double hit on the motor neurons, both upper and lower. So the two upper motor neuron pathways that are mainly affected in ALS are the corticospinal tract, which will, of course, give the patient upper motor neuron spastic weakness, and the cortical bulbar tract, mainly the cortical bulbar tract that goes down to the medulla. And so these patients have dysarthria and dysphagia from degeneration of the cortical bulbar tract. Now, we call this, when it's a cortical bulbar tract degeneration, we call this a pseudobulbar palsy. The bulb sometimes refers to the brainstem, or often neurologists will use it to refer to the medulla. And so the lesion is not really in the bulb, it's to the pathway that is supplying the bulb. And so in pseudobulbar palsy, it's dysarthria, dysphagia, and usually, not a very flattering term, but it's called emotional incontinence. And these patients have great difficulty controlling their emotions. They cry or laugh at something that isn't that sad or isn't that funny, and they're embarrassed about it. So watching a movie, they will tell you, they just don't understand. They've watched that movie 3 times, and now they just can't control their emotions. That's a good description of pseudobulbar palsy. I do want to emphasize that the lesion here is not of the corticospinal and corticobulbar tract. The lesion is of the neurons, the motor neurons that are in the cortex. And if you destroy the neuron, then of course the pathway is going to degenerate. So it's motor neuron disease. All right, so just a reminder of the cortical bulbar tract, which travels through the genu of the internal capsule. And importantly here for ALS is the lack of innervation of the nucleus ambiguus. Remember, that's motor for 9 and 10, and the hypoglossal nucleus for the tongue. So that's why there's a lot of dysarthria, dysphagia. Now, it's motor neuron disease, so lower motor neurons are also involved. And in the spinal cord, the anterior horn cells degenerate. So these are complex cases because sometimes it will start out more with upper motor neuron degeneration, sometimes it will start out more with lower motor neuron degeneration. And so lower motor neuron findings, of course, are a flaccid floppy weakness, loss of reflexes. Fasciculations are just classic for ALS or any anterior horn cell disease like polio, and atrophy. So you have this patient with a mixture of upper and lower motor neuron findings. Okay, those two lower motor neurons in the medulla I just talked about, nucleus ambiguus and hypoglossal, degenerate in ALS. So that's why the dysarthria and dysphagia is so rapidly progressive in these patients. That's why the weakness is so rapidly progressive. It's a double hit. Now, if the degeneration starts in the nucleus ambiguus and hypoglossal, then we call the dysarthria and dysphagia a bulbar palsy because the problem is in the bulb. And one difference between bulbar palsy and pseudobulbar palsy is that in bulbar palsy we don't have the emotional incontinence. And also in bulbar palsy, the patient is usually going to have tongue atrophy from degeneration of the hypoglossal nucleus. So onset of symptoms in ALS can start either with weakness in one arm or one leg. This is painless, and so patients will come in like with a foot drop and say, it doesn't hurt at all, I just can't move my foot. That would be a kind of a typical story. About 20% of cases will start with dysarthria or dysphagia. So what is preserved? Well, in the brainstem, areas above the medulla are preserved. They may not be involved at all, or they may be involved later. And so remember, the medulla is not really involved in eye movements. And so eye movements are relatively preserved in ALS. Cognition in most patients is relatively preserved, although I'm going to kind of tease that out here in just a little bit. Sensory nerves are largely unaffected, so this is motor neuron disease. And interestingly, the bowel and bladder is uninvolved. So I will talk about the anatomy here of the bladder in just a little bit, and the anterior horn cell that supplies the external urethral sphincter called Onuf's nucleus. And for reasons that are difficult to understand, that anterior horn cell is preserved in ALS as compared to all the other anterior horn cells. So in ALS, again, the problem is up here with the motor neurons, and then through Wallerian degeneration, the pathway degenerates. Okay, and so the lesion is up here, and the lesion is of the anterior horn cells here. And so I like the way the student drew this one, that notice the line is just above the mouth, because the symptoms are really from the mouth down. Dysarthria, dysphagia, and then significant extremity weakness. If we do an MRI scan, sometimes we can actually see the Wallerian degeneration of the corticospinal and corticobulbar tracts. So here it is degenerating right here. All right, so ALS occurs in about 2 per 100,000. No more than 10% of cases are familial. So usually this is sporadic. When it is familial, it's usually autosomal dominant. And so there are other family members that are known to have had it. 60 is kind of a typical age of onset for ALS. Familial ALS tends to occur late 40s, at least 10 years earlier. All right. We think, however, that ALS is underdiagnosed in the elderly. So someone in the nursing home who in the last 6 months of life just got really weak and then passed away. Oftentimes that individual was never seen by anyone. It was just assumed, well, they were really old and they passed away. So Probably the true onset for ALS is older than 60, but that is not really known for sure. All right, now the genetics of ALS. The first genetic lesion in ALS was discovered in 1993, and this is the gene for superoxide dismutase. And this is, again, autosomal dominant, and there have been way over 150 mutations, and this actually is not very common. It only makes up about 10% of familial ALS cases, therefore no more than 1% of all ALS cases. All right, but that one is just known because it was the first one. Much more important, and the one I really would like you to remember is the next one, and which is a C9orf72 mutation. Okay, this is also autosomal dominant, and the reason I think this is significant is that almost half of familial ALS cases are due to a mutation here, and in up to 8% of sporadic ALS we can find a mutation here. The other important tie-in is that ALS is related with a dementia syndrome we'll talk about later called frontotemporal dementia. So no more than 10% of patients with ALS have frontotemporal dementia. And if you do detailed cognitive testing in someone with ALS, up to 50% have some cognitive or behavioral symptoms. I have to say I did a fellowship in ALS at the Cleveland Clinic and saw lots of ALS patients over a year period of time, and I really did not appreciate much cognitive or behavioral symptoms. But if you do detailed testing, you can detect that in a surprisingly high number of patients. But it's only 10% that have the real significant frontotemporal dementia. Okay, and I'll just add for interest here that it's been discovered recently an RNA binding protein that abnormally folds in both sporadic and familial ALS. This is called TDP43, and it may give us some clues or possible windows into new therapies. So again, the C9orf72 of everything on this slide, that's the one to focus on and the one that I will ask you about. So I said onset around 60 is kind of a good ballpark number for ALS. Most patients die within 3 to 4 years of the onset of symptoms. However, if someone starts out with dysarthria and dysphagia, especially if it's bulbar, those patients usually, the prognosis is like around 12 months or even less. Now, motor neuron disease is a spectrum disorder, so some patients will have only lower motor neuron findings throughout the whole course, and that's called progressive muscular atrophy. Some patients will only have upper motor neuron findings throughout their course. They never go on to get the lower motor neuron stuff, and we call that primary lateral sclerosis. Both of these kind of pure variants are much less common than just regular ALS. And oftentimes I've seen patients who for years had what looked like primary lateral sclerosis, and then all of a sudden they began to get lower motor neuron findings. So sometimes this can be present in a rather slow manner that's unpredictable. All right, so the medication that's been out for some time for ALS is riluzole. In the most optimistic kind of spin we can put on this medication, it extends life for about 2 to 3 months. So many patients and families, when I explain this, will choose not to go on the medication. But it's pretty well tolerated. It acts probably through blocking the release of glutamate. And remember, glutamate has several receptors. One of them is the NMDA receptor here. So there's glutamate. And so perhaps by understimulating this NMDA receptor, that the idea is maybe glutamate through NMDA receptors is toxic or abnormal to motor neurons in these patients. There's a newer medication that came out a couple of years ago called edaravone, which is a free radical scavenger. I won't ask you about that. Its role in the treatment of ALS is not clear at this time, I would say. And just today, if you can believe it or not, I heard about this yesterday, but there was an article published in the New England Journal Obviously not something I would ask you about. I'm just kind of pointing this out for interest, that this was actually rather encouraging, what was found in this study. And so there's a lot of interest. For years, things have been tried for ALS without much panning out, and there's been a lot of progress in the last 5 to 10 years. So I'm hopeful we'll have a more meaningful therapy for this condition soon. Now, a few conditions that mainly affect sensory pathways in the spinal cord. Most common is syringomyelia. Syringomyelia is a central cavitation of the spinal cord, and this is related either to trauma, so someone maybe was in a car accident and had some shear force damage to the spinal cord, and then over time that can just lead to a slow cavity building up in the center of the cord. The other thing that is commonly associated with is Arnold Chiari type 1 malformations. And Dr. Deich will explain this in more detail, so I'll just kind of give you the big picture here. In an Arnold Chiari malformation, we have low-lying cerebellar tonsils. These are extending down through the foramen magnum. Okay, so that is abnormal. And these low-lying tonsils tend to promote the development of a central cavity in the cervical cord. And there's some different theories for why this develops. One is that cerebral spinal fluid is actually produced in a pulsatile manner. And if you have this tight space right here, and you have this CSF, being produced in a pulsatile manner, it may just gradually, affect this area of the cord and cause it to widen. So syringomyelia almost always first involves the crossing pain and temperature fibers right here, the ventral white commissure. So notice this is coming from both arms. They cross right here. And so if the lesion starts in C5, which would be a common place for this to start, then patients will have a loss of pain and temperature in bilateral C5 dermatomes. Okay, now if it grows down this way, which it frequently would, then as it extends to C5, the numbness would go down to the thumb, loss of pain and temperature. If it goes down to C7, now we'll extend out into the index, long, and ring finger. Okay? And so there's a loss of pain and temperature in this distribution. Rarely it can go the other direction and involve the medulla, in which case we call it syringobulbia. Here we have that term bulb again. And patients may have some dysarthria and dysphagia from the medullary involvement. All right, so boards have been in a rut for 20 years, I would say, and they always ask a question about someone who burns their hands, like cooking food, because they don't have good pain and temperature sensation. So if you see that vignette, almost certainly they're asking you about syringomyelia. Now, it's not common, but if these grow really large and extend laterally, then you can have some upper motor neuron findings from involvement of the corticospinal tract, but that would always be a much later development. Tumors can grow within the spinal cord, as I mentioned, so these are called intramedullary tumors. Ependymomas and astrocytomas are most common, and so these tend to start in the center of the cord, and they grow out a little differently. They tend to go out this direction to the spinothalamic tract. Okay, so I can't say that I've seen this very often, but if you had a spinal cord tumor, let's say at C5, and it grew out in this direction, okay, well notice the columnar arrangement of the spinothalamic tract, the sacral fibers are way out here. So this patient may have a bilateral loss of sensation, pain and temperature sensation involving cervical, thoracic, lumbar, but then you get down to checking the sacral dermatomes, and they're normal. So that's called sacral sparing, and if you see that, the lesion has to be within the spinal cord. All right, B12 deficiency, otherwise known as subacute combined degeneration. The name there kind of indicates that, this comes on in a subacute manner over weeks to months, and multiple pathways are involved, not just one. So most often these are older individuals, and you will learn about in pathophysiology and pathology is due to pernicious anemia, where we have decreased absorption of B12 from involvement of the gastric parietal cells. So the most important thing from a neurologic presentation, or I would say the most common presentation, is dysfunction of the posterior columns. And so patients on exam have a loss of vibration and proprioception. Okay, I've never had a patient come in and tell me they can't sense vibration, right? And you're just not going to be aware of that. But they are coming in because they're falling. They don't know where their legs are in space. So presentation of B12 deficiency is usually gait instability. But other pathways are affected as well. The corticospinal tract is affected, and that will result in some upper motor neuron findings. And the small pain and temperature fibers are affected in the peripheral nerves. So these patients also have a stocking glove sensory loss. So you can't localize this to one place. So I would just say the rule of thumb is if you see a patient that has profound loss of vibration and proprioception, you should just always check a B12 level. It's an easy thing to do. Make sure you're not missing that. All right, now if we do an MRI here of the cervical cord, you can actually see the degeneration here of the posterior column. And a nice drawing that a student did for me showing you the posterior column involvement and the lateral corticospinal tract involvement. All right, and a reminder that falling is the presentation. Now, B12 can do a lot of other things. With regards to the nervous system, it can affect the optic nerve. So if we have a case of unexplained visual loss, and it looks like the lesion is in the optic nerve, well, we should be checking B12 level. B12 is also important for normal cognitive function, so these patients can have confusion. So later on when we talk about dementia, in a workup for dementia, we always check a B12 level in these patients. And B12 deficiency can cause an altered taste sensation. That's known as dysgeusia. Okay, you will learn about all kinds of non-neurologic manifestations of B12 deficiency, including glossitis, vitiligo, prematurely gray hair, anorexia, and a megaloblastic anemia. So it can do quite a lot. So when we're thinking about this, of course, get a B12 level, but it isn't quite that easy. So most labs will say under 200 is abnormal, but you can have symptoms from B12 deficiency, even when B12 levels are up to 350. And I can just say from having checked this on many, many patients, frequently in the elderly we'll get a B12 level of 300, 250, 330. And so how do you know? Is that normal or abnormal? And so what we like to do is we combine this with a methylmalonic acid, which is actually more sensitive for detecting symptomatic B12 deficiency. So if your B12 level is borderline and your methylmalonic acid is elevated, then you want to assume that patient has symptomatic B12 deficiency. They need to be treated. Okay, homocysteine levels would also be elevated. In neurology, we don't routinely check these because these can be elevated due to other things. And so we usually will just add a methylmalonic acid. All right, so we used to do B12 injections for patients that had low or symptomatic deficiency. And it looks like if you just give a very high oral dose, even if they have a malabsorptive issue, that still is an effective treatment. Now, tabes dorsalis also affects the posterior columns. It's more limited in scope of involvement. This is usually seen in patients who are HIV positive or have AIDS. And one difference here is that the nerve roots here, the sensory nerve roots, are affected. So these patients usually have radicular, painful symptoms. All right, so here's a drawing of tabes. Here are the dorsal nerve roots. And this patient is not only falling, but the patient has back pain. Okay, something else that can affect the posterior column is a stroke. And this involves the posterior spinal artery. This is not very common, but if we have a stroke here, then patients will acutely be very unsteady on their feet. And they have a severe loss of vibration and proprioception below the level of the lesion. But notice they won't be weak because the corticospinal tract is fine. They won't have loss of pain and temperature because spinal thalamic tract is fine. And you could easily distinguish this from B12 deficiency or tabes dorsalis because it's a stroke. It comes on suddenly. All right, the hereditary myelopathy, there are several of these, but the only one we'll talk about for now is Friedreich's ataxia. Okay, this is autosomal recessive, comes on in younger individuals, and it involves multiple neurologic pathways, which is why these patients are so devastated. So it involves the spinocerebellar pathways out here, and so patients do not get information to the cerebellum about where their arms and legs are in space. So they have a severe ataxia. They also have a peripheral neuropathy, and so even getting that information to the spinal cord isn't adequate, so they have kind of a sensory ataxia as well. And you can see here quite profound posterior column involvement, so severe loss of proprioception, falling. And here's the cortical spinal tract here, and so they're going to have spasticity. So a lot is going on here in these patients, but it's fairly rapidly progressive gait instability is the usual story. So this is our second condition that is a trinucleotide repeat. So remember myotonic dystrophy, and now Friedreich's ataxia, which is GAA repeats on chromosome 9, so we can do a genetics testing for this. And then just add on the margin of your handout, Huntington's disease is the other trinucleotide repeat disorder. All right, so let's finish up. We didn't do this last year, but if we're going to understand abnormalities of the bladder, which are very common in spinal cord lesions, we need to understand a little bit about the anatomy. So we have the somatic motor system, which, as we've always described, is voluntary control. So the anterior horn cell involvement of the arms and legs, that's a somatic motor system. And we have a somatic motor system for the bladder as well. Sympathetics and parasympathetics act to either prevent voiding in the case of sympathetics or to stimulate voiding in the case of the parasympathetics. So let's describe here what happens with normal filling of the bladder. And of course you don't want your bladder just to empty involuntarily. And so what happens here is the bladder fills is that we have these little mechanoreceptors in the bladder that stimulate the pelvic nerve. Okay? And so this information will activate sympathetic neurons here, which supply the bladder via the hypogastric nerve. And remember, sympathetics want to inhibit voiding, so it actually inhibits the detrusor. Okay, and not shown here, the sympathetics also contract the internal urethral sphincter. So by two mechanisms, it will inhibit voiding. Okay, and the pelvic nerve also will activate these anterior horn cells. This is Anuff's nucleus. These are somatic motor neurons, voluntary control. So it activates them to keep your external urethral sphincter closed down tightly. Okay, so that's normal filling. Now, I should also say that that information also reaches areas higher up in the brainstem. So it goes up to the periaqueductal gray. And remember that this is the area around the cerebral aqueduct in the midbrain. And not shown on this diagram, but this also goes up to the paracentral lobule in the prefrontal cortex. Remember that the paracentral lobule supplies the leg with motor and sensory information, and also the bowel and bladder. And so now the brain is aware of the state of filling. So maybe you really have to go to the bathroom now, and it's really bombarding the paracentral lobule. You're consciously aware of that. Okay, and so what happens with voiding? Well, the paracentral lobule prefrontal cortex will activate the periaqueductal gray, which will then activate an area in the pons called the pontine micturition center. And this seems to be kind of the key switch then. And we can kind of imagine, well, what needs to happen then to empty the bladder? Well, we know that the sympathetics act against emptying the bladder. And so we need to inhibit the sympathetics right here. And we know that the somatic motor neurons are also normally keeping the external urethral sphincter shut. And so when you decide to go to the bathroom, to use that kind of terminology, well, you need to inhibit these anterior horn cells to then open the external urethral sphincter. Okay, and now we just need to activate the parasympathetics, which we can see right here. Okay, and so the parasympathetics, and I would just draw a circle around this. This is all the pelvic nerve right here. So pelvic nerve provides sensory input about state of bladder fullness, but also the parasympathetics travel through here through the pelvic nerve to stimulate the detrusor muscle. So the bladder contracts, sphincter opens, and successful voiding. Now I want to go over a really nice drawing that a medical student did for me last year to kind of show, to include the neurotransmitters in this. And the reason I wanted to have a drawing of this is you can really only understand medications that are used to treat bladder dysfunction if you understand the neurotransmitters. All right, so remember, for emptying the bladder, we need the parasympathetics. You're traveling with the pelvic nerve. And parasympathetics, remember, use acetylcholine on muscarinic receptors here on the detrusor muscle. These are M3 receptors to activate the detrusor muscle for bladder emptying. The sympathetics want to do exactly the opposite. So via the hypogastric nerve, the sympathetics will inhibit the detrusor muscle, and sympathetics here use norepinephrine. So it will inhibit the beta-3 receptors to inhibit the detrusor, and it will also act on these alpha receptors on the internal urethral sphincter. Notice this stimulates these to contract the internal urethral sphincter. So again, when it's time to void, this is inhibited, and the internal urethral sphincter opens, and we lose that inhibition on the detrusor muscle, so it can contract. And then here we have a nucleus, these anterior horn cells that travel with the pudendal nerve, and these normally contract the external urethral sphincter via acetylcholine. Okay, so having said all of that, let's go through some abnormal conditions and then talk about one medication that we use for one type of urinary incontinence. So if we have a lot going up here in the paracentral lobule, prefrontal cortex, then that area, where we decide to go to the bathroom, is not functioning. And so this can happen frequently in Alzheimer's disease. And what happens there is all the lower spinal cord brainstem things are working, but the cortex is not. And so these patients void every time their bladder begins to fill. Okay, so this MRI, we see a lot of atrophy, like in Alzheimer's, but this could happen with a tumor, like a meningioma here, or an anterior cerebral artery stroke could also do that. So patients have no voluntary control, and they need to wear diapers or have a catheter or something like that. Now, if we have spinal cord compression, let's come back to this case of motor vehicle accident with cord trauma. These patients go through initially what is usually a flaccid or atonic phase. Remember I talked about spinal cord shock? Okay, similar kind of a mechanism here. And so what happens here is there's a loss of supply innervation to the detrusor muscle. It becomes very weak and floppy, but yet the sphincter tends to be contracted. And so this is really an emergency. These patients come in, they're weak below the level of the lesion, but don't forget about their bladder. And so they try to go to the bathroom, they can't. If you put a catheter in, you get what's called a very high post-void residual. And so these patients usually need to have a catheter for a period of time because they can't go to the bathroom. I should say they can't empty the bladder. Now, over time, these patients will merge into the spastic phase. Okay, this is called urge incontinence. And what really happens here is they can't coordinate the action of the detrusor muscle and the urethral sphincters. They're out of sync. And so patients have a very tight detrusor, and so they often are having painful kind of spasms and leakage of urine. And if you do a post-void residual in these patients, it isn't nearly as high as what you see during the flaccid or atonic phase. And so these patients, and this could be multiple sclerosis, like a patient with transverse myelitis, cord compression, anything that affects the spinal cord. Eventually, we're usually dealing with this spastic phase or urge incontinence. So oxybutynin is a medication that can help during this stage. So to come back here, oxybutynin blocks these muscarinic receptors of the parasympathetic system. And so remember, we have a spastic bladder here. And so by blocking acetylcholine on muscarinic receptors here, the detrusor muscle is able to relax, and the spasms aren't as bad, and so they're not having as much of the urge incontinence and leakage of urine. Now, if we have a lower motor neuron problem, like cauda equina syndrome, or we've got something maybe in compressing the cauda equina, the conus medullaris, this can lead to just involvement of the lower motor neurons here, like onus nucleus, and can also affect our parasympathetic outflow to the bladder. So this is called a flaccid bladder. And so these patients have an overflow incontinence. There's decreased tone to the detrusor muscle. So it gradually builds up, and then there's just a continual leakage. And this can be very difficult and challenging to treat. All right, I'm going to cross my fingers that this recording worked, and hope all of you guys are well.